Okay. Are we recording now, Jess? Yes, we are. Bonjour, hello, my name is Joanna Vautour. I am Anishinaabe Kwe, a member of Serpent River First Nation. I will be your moderator today for this webinar, Transforming Pediatric Palliative Care, Improving Access and Enhancing Quality Care for Indigenous Communities. I welcome you all for taking the time to listen with an open heart and mind to Elder Dorothy Keon, who will offer cultural support with an opening and closing, and our guest speakers, Goodman and Dr. Dave Lysecki, as we learn about pediatric palliative care. I would like to take a moment to read the First Nations Child and Family Caring Society honoring the memory of Jordan River Anderson, a young boy from Norway House Cree Nation in Manitoba who was born in 1999 with multiple disabilities. He lived over 2 years in a hospital because federal and provincial governments could not agree on who would pay for his at-home care. This is because federal and provincial territorial governments cannot agree on which government should pay for services to First Nations children on reserves. So they typically do not provide the service until they can sort out the payment issue. Unfortunately, Jordan died at the age of 5 before he could experience living in a loving home. Jordan's death ignited a movement to uphold human rights for all First Nations children through the creation of the Child First principle called Jordan's Principle. Jordan's Principle is a legal rule and Child First principle named in honor of Jordan River Anderson. It ensures that First Nations children receive the services and support when they need them. And so we want to take a moment to honor Jordan River Anderson for teaching us and awakening us to pediatric palliative care. And so now I would like to invite Elder Dorothy to start us off with some opening words.
Miigwech, Din Kwe, Dijnakaz, Mishkigan Dodem, Elliot Lake Dunjaba. So in my introduction of myself, I said that my spirit name was Blue Jay Woman, and I'm from the Turtle Clan, and I live here in Elliot Lake in Northern Ontario. This is a traditional introduction, not only to those who are listening today, but to those in the spirit world as well, so they know who is petitioning them. To start off with, I'd like to say Miigwech, Miigwech, Creator, for all that we have. Miigwech for this beautiful day here in Elliot Lake. The snow is blowing, the wind is blowing, and everything's alive with snow right now. It's beautiful. I would also like to request our ancestors to be with us today. As we work together, we're asking for guidance to work towards the palliative care services that we're offering to our First Nation children, because our children are gifts to us from the Creator, entrusted to us to care for them in the best way that we can. So we're asking the spirits, our ancestors, and those around us to help us and guide us so that we can care for our children in a good way, to give them a good life while they're here with us. Miigwech.
Miigwech, Dorothy. I would like to now invite Kira and Dave to share with us about their work in pediatric palliative care.
Thank you so much. I'm going to bring up the slide deck. Okay, all is well.
Slides look great.
Good. Kira, do you want to start?
Sure. Thank you again for having Dave and I here today to start this conversation with all of you that have joined us. As Joanna mentioned, we're going to be discussing transforming pediatric palliative care and how we can improve access and enhance quality for Indigenous communities. So if you want to take us to the session objectives, Dave. So today we're hoping that you can walk away with the following, and that we'll be able to walk away with some things as well. So we are hoping that you feel that you can identify the components of what high quality pediatric palliative care are and some of the unique challenges in delivering this care. We're also going to tell you a little bit about Canada's Pediatric Palliative Care Alliance and hopefully explore some opportunities for collaboration that will help us improve access to care for children who come from Indigenous communities, as well as looking at rural and remote communities, if that comes up today as well. So Dave, do you want to introduce yourself first and what brings us here?
Sure. I'm not on mute, correct? Can't
No.
see the thing right. So my name's Dave Lysecki. I am in Hamilton, Ontario, which is also where I was born and work. My family has been here in Canada as uninvited guests for many generations, and I'd like to recognize that I have the privilege of living and working on lands cared for many generations by the Haudenosaunee and Anishinaabe nations, on lands agreed upon by the Between the Lakes Treaty and protected by the Dish with One Spoon Wampum Agreement. I will let Kira acknowledge where she's presenting from, and then I would love to talk a little bit about my experiences in healthcare and pediatrics, and intersection with First Nations, Inuit, and Métis people.
Thanks, Dave. Similar to you, my family has been here as well for generations as uninvited guests. I'm speaking to you today from Ottawa, which is on unceded Algonquin Anishinaabe territory. And I'm very grateful, as we've said, to have a chance to come here and share. I am a nurse by background, and I'll just go on and tell you a little bit of my experience in pediatric palliative care and then pass back to Dave. I came to pediatric palliative care on a rather roundabout journey, which is not an uncommon thing to hear from people that reside in the space. I was a labor and delivery nurse in the city of Toronto and had an opportunity to work both in project management and as a clinical manager with the Sick Kids Pediatric Palliative Care team, as well as at Emily's House, which is the children's hospice there. I've come here today in the hopes that we can start a conversation that will help us all better understand this really unexplored topic of ensuring access to high quality care for Indigenous children and families. And I've not had much opportunity through my clinical work to be able to listen and learn from families, Indigenous children and families who are seeking this type of care. But I have been fortunate to be able to have some conversations in my current role as project director for the Pediatric Palliative Care Alliance. And they've always been enlightening, and I've learned so much. So now I'll pass back to you, Dave.
I just want to highlight some of my experiences that bring me here today. Certainly not as an expert in First Nations, Inuit, or Métis health, and a theme that Kira and I are coming with, and as you'll see in the talk, is we are here to learn. We hope that we have some to share as well. I've certainly cared for many children who have palliative care needs, and we're going to sort of describe a case like that as we walk through these slides, but really looking for group learning here today so that we can all share and learn, but also that the work that Kira and I are doing, and we'll be introducing you to something called the Canadian Pediatric Palliative Care Alliance, is really looking for partners and information and lived experience to get pediatric palliative care right across Canada for all Canadians. And we recognize that we need partners within and who support our communities of Indigenous Canadians. We're really here, not coming as the experts, but coming as people who have an opportunity to bring people together and to raise voices, and looking for partners and help and support in making sure that we make this care right and equitable for all children across Canada. Some of my clinical experiences, I'll be honest, I went to medical school in 2006 to 2009, and I recall very little focus on Indigenous health in my medical school education. When I went to pediatric residency, I did that in Kingston, Ontario. And Kingston serves as the tertiary center for Moose Factory, Moosonee, and Attawapiskat. And so commonly we would have patients from those communities who were flown down to receive their tertiary pediatric care, and often end-of-life care in Kingston, far away from their support in their community. I experienced more of that in my time at CHEO in Ottawa, where I both worked in CHEO, experiencing children, particularly from northern communities, coming down to Ottawa for care, but also having gone up to Nunavut and working in Iqaluit, and similarly seeing reaching a limit very quickly as to the care we could offer there, and sending patients down to Ottawa, and once again taking them out of their homes, out of their communities, out of their connections to the land and the people, and their cultural and familial supports, and often receiving end-of-life care thousands of miles from home. One of the things that we hope to achieve long term is a better network of support, so that we can keep children in their home communities to receive all the care they're entitled to, which includes good, high quality palliative care. Go ahead, CERAH.
So I think now, Jessica, you're going to flip us into the Menti. So for those that can, we would love it if you could go to menti.com and enter the code 41778463. There's a QR code there that you can scan as well. And we're hoping to learn, similar to how Dave and I have spoken of what has brought us here today and our hopes for today, what motivated you to join today's webinar. And we'd appreciate anyone who can add their voice there to give us a sense of what's brought people here today. It'll help Dave and I make sure where we can speak to those things, and then where we can't, we can connect afterwards and help navigate people to those resources as needed. So seeing lots of responses about how this is a new space for many of us, and wanting to learn more. Some people who work in this space and some people who've come here with curiosity. Lots of experience on the line with us today that we're really happy to have here and to be able to listen and learn from. It seems, Jessica, that things are slowing with the responses. I'm happy to, if I don't know if you want to add anything or.
Only that I share in so many of those goals that
Yeah.
this is a learning circle, I hope, and we're all here to learn from each other. And we don't expect also to have all the answers today. What sometimes the learning starts with exploring what are the right questions, and what are the problems. And I know that a lot of people on this call have sort of excellent insights into obstacles, and we're here to help sort of facilitate that.
Mhm.
One of the things that we opted not to do was a 60-minute presentation on sort of what is pediatric palliative care, what drug doses do you use, the details of it, but really highlight the spirit of it, the relational aspects of it, and partnerships required to achieve it, and to hear from you how you see that working, what you see working well, what you see as obstacles in delivering that care, and really starting a conversation to move this field forward.
Yeah,
So
exactly.
I'm
The
happy
first of many conversations. Yeah.
to share my screen again whenever, Jessica.
I think we have one more mentee question as our next one, which is, we were just hoping to get a bit of a sense of where everyone is joining us from. Again, just to help us anchor in what we're sharing about, and just get a feeling for where we're all coming together on this online platform today from. Understandably, lots of dots popping up in Ontario. And one person in the Atlantic Ocean. That's great. Thank you. We appreciate you sharing that with us. It gives us a good sense of who's here today, although I'm sure there's others from other zones that weren't able to contribute there as well. All right, Dave, I'll mute myself and let you get going.
We'd like you to introduce you to a theoretical infant by the name of Jane. Jane is an infant with trisomy 18, born unexpectedly with that diagnosis. Trisomy 18 is also known as Edwards syndrome. It's a genetic disorder. It causes severe developmental delays and a spectrum of medical issues related to an extra chromosome, number 18. Jane has parents Shauna and Jim, and siblings Jesse and Jacob. I want to highlight that Jane is an example of a pediatric palliative care case. I've not made specific reference or made Jane specifically of any First Nation or Indigenous background. We're just going to walk through how we put the pieces together for pediatric palliative care cases, and think about how we can use an Indigenous healthcare lens on a case like Jane's. So a story like Jane's typically begins in the NICU if it's not diagnosed prenatally. It's described to the family that this is unfortunately a life-limiting condition. They're told that most children with trisomy 18 do not survive the first year, but beyond that, we really can't be more certain. We have to take it day by day. The family's told that Jane is stable now, and there are going to be many opportunities for precious family moments. And they're informed that there's a pediatric palliative care program who the team thinks they'll be beneficial in their journey, and are going to come meet them and Jane. what is hospice palliative care, pediatric palliative care? Well, this image was created by a partner of mine, McMaster, who unfortunately himself is now deceased, and represents a framework of the Western concepts of palliative care, which can map to many environments and cultures. But essentially, it describes palliative care, or a palliative approach to care, existing at the intersection of these three areas, where really it's a focus on quality of life, that the intentions of palliative care are not necessarily life prolongation the way they are in much of medicine, but really looking at how is that life lived, how is that life experienced, and how can we make it as positive as possible. It's whole person care. So when considering quality of life, it is not unidimensional, looking at simply physical symptoms, but looking at spiritual elements and cultural elements and emotional elements and psychological elements. And of course, so far, those two things are something that happens in some places in all of medicine, and where the third part that's required for sort of it to be palliative care that we're delivering is this acknowledgement of mortality, that the condition we're dealing with or discussing is life-threatening and potentially life-limiting, and thinking about quality of life and thinking about whole person care with that understanding and focus on the connection to life and death and the world after death. The intersection of these three concepts can really be applied to anyone at any time, in any setting, and in any disease. And so palliative care historically has had a problem with being the delivery of it being majority for adults with cancer whose cancer treatments can no longer cure them. And that's the place of palliative care. But really, this approach can be applied in so many more scenarios. So for Jane, that approach can mean in the NICU, Shauna and, that should be Jim, Shauna and Jim being supported by the NICU social worker and getting regular updates and meetings with the NICU interdisciplinary team, including the doctors, the occupational therapists, the nurses, the spiritual care provider, perhaps. Together, they decide to place a G-tube in Jane to facilitate getting her home and care at home. So a G-tube is a surgical tube, for those who may be unfamiliar, that allows for the delivery of feeding without Jane needing to do the work of swallowing, which can be high risk in some of these children. The child life specialist at the hospital works with Jacob and Jesse, the siblings, to support them through visiting Jane, understanding why she's in the NICU, understanding her extra chromosome and what makes her unique, understanding the G-tube and why it's being placed. And the palliative care team sits and helps discuss what's expected for Jane in the future, and how other parents in similar situations like this can make decisions, face the future, and provide them with resources that are helpful moving forward. So when it comes to wanting to get Jane home, we need routine newborn care. Someone needs to be checking her weight and assessing her for immunizations and acute infections or intercurrent illnesses. We need pediatrics and developmental care, somebody who's looking at her big picture in terms of her trisomy 18, her development. We need likely home care and equipment to help with the G-tube and her other perhaps physical needs. The family may need financial support. Generally, a child like this means at least one of the parents needs to go off work, generally permanently, to provide support for the child. And there are a number of government funding programs that they may have access to. This is a great emotional toll that can be placed on the parents, and really supporting them in their own mental health is a critical component. Ongoing support for the siblings through changes in Jane's health is important. Respite, which is short breaks where people can take to sort of recharge their batteries, is important. Respite can occur in home when caregivers come into the home and allow the parents to take a break, or out of home respite, which often happens in some community centers or pediatric hospices like Emily's house that Kira mentioned. It's expected that Jane will have symptoms that arise as a result of her medical condition, and having a clear plan that the family has, but also the community care team can all reference the same plan is important. And an advanced care plan that describes, well, what happens if we see signs that Jane's body's starting to shut down? What do we do at the time of death? All of those are needs that we need to plan for and have in place to get Jane safely back into her community. And so we want to go back to Mentee and ask you guys to share perhaps some real strengths and enablers in communities that you've worked in to getting that kind of support home and Jane home, but also some barriers where you've experienced challenges in providing care, whether it's children or adults, but where you can imagine that there might be some real difficulties in getting that sort of wraparound care for this family in their community.
Jessica, on the screen is coming up and needing to enter the code to join for the Mentee.
Sorry about that. Is that better?
Yeah, great.
Thanks.
Thank you.
Trust. Trust goes many ways. I'd love to hear more. I imagine you're referencing the family trusting external care providers, but I've also seen the hospital providers not trusting external providers, or external providers not trusting the hospital care. I mean, that one can go many ways. Fewer specialized and psychosocial supports available in person, lack of accessible resources in home, availability of in-home supports. These all resonate. Lack of nursing support in community, potential lack of bereavement, formal grief and bereavement support for the family. Grief support early on is just so critical in the journey, in processing all of the events and decisions that occur going forward. And all too often that label and that type of support is reserved for after someone dies, when really we need to be engaging that kind of support early on. Lots of recognition here for parents and caregivers, distance to the hospital, large family and community networks as an enabler. Nursing, medication, time for input from elders, and cultural integration.
I love the comment, small communities come together differently, sometimes more effectively than over-resourced urban centers. I've heard that in a few conversations anecdotally over the last year of the project, and lots of stories of when that's happened. And it's really interesting to look at those moments of light when difficult things are happening, and try to figure out why they work so well.
Well, I just want to point out time, and I know you have a lot more to share with us, so maybe we could switch back to the presentation.
Thank you. So what are the kind of resources that are needed to meet those needs? You know, ideally we have a family health team, an interprofessional team that can provide routine newborn care, care for intercurrent illnesses, immunizations, a consultant pediatrician to look after some of those developmental and pediatric specific needs. Perhaps that pediatrician it works with a local hospital that has a pediatric ward or the capacity to admit pediatric patients for some of the less sort of tertiary needs. And a partnership and preparation can be made at that hospital. Working with home care and equipment can be challenging, and so thinking about unique strategies to optimize the resources we have, such as there are things called like e-shift, where perhaps instead of a nurse being in the home, it's a personal support worker who has the nurse available through video or phone. Connected care is something that's out of Sick Kids. There are more and more virtual options to support people in the home. Financial programs that exist, a community center that might provide some rehabilitation and recreation, parental counseling. Again, you know, in-person access may be difficult. There are more and more virtual options and virtual services to access. Sibling support, supporting them not only with getting to know and accept the trisomy 18, but also supporting their journey as things evolve and change. Maybe finding some in-home respite, and there is funding for that, as well as local cultural, spiritual care. And with Jane, we didn't, as I said, explicitly make her a First Nations child, but if she were, certainly traditional medicine and traditional healers and having access to that. So we really try in pediatric palliative care to think about this care network that surrounds a child and their family, thinking about what aspects of needs do they have, medical sort of, you know, focus on medical needs in terms of diagnosis and prognosis and counseling and nursing needs in terms of daily requirements, case management, coordination, social work needs, child life needs, spiritual and cultural needs, bereavement and grief needs. We try in as many communities to identify these resources in the communities themselves and provide some backup support with the pediatric palliative care specialist teams located out of the children's hospitals. And when those partnerships work best, it is a sharing of knowledge, bidirectional. It also allows, and one of the reasons that Kira and I are here giving this presentation as non-experts in Indigenous healthcare is the role of the specialist services is able to look at the big picture and have time to focus on how do we make this system work for everybody, and that requires education and fundraising and awareness and research. And so this is where Canada's Pediatric Palliative Care Alliance comes in, and I'm going to hand it over to Kira to discuss a little bit about the Alliance.
Thanks, Dave. So yeah, just to echo what you've said throughout, this model requires connecting, empowering community partners with resources. And when you see those circles, and Robin, thank you for adding community to those inner circles as well, you can see how a collaborative model of care could look, and you could see how it could work. And we at the Alliance are bringing this project forward as a way to help build community partners up with resources. So I'll tell you a little bit about how we came to be. Dave, if you can switch us to the next slide. So our origins are back in 2018, Health Canada developed a framework on palliative care. And in 5 years later, in 2023, they wanted to do a report on how the framework was working and how it was going. They reached out to the executive director of Roger Neilson Children's Hospice. Her name is Megan Wright. And they asked her to give them a sense of the current state of pediatric palliative care in Canada. And she was able to share that Roger Neilson Children's Hospice has had an opportunity to support the development of some teams and recently some hospices, some children's hospices across the country. They were very interested in that work. and wondered if our Roger Nielsen Children's Hospice would be interested in doing a closed grant submission to build a resource hub that would contain all of the things that the team had already been sharing with folks across the country. So it ended up being up to $1 million over a 2-year period that was given. And once the signed contract was placed into our hands in January of 2024, we immediately began the process of searching out partners across the country. This is not work that can be done by one person, one organization, or in silos any longer. In fact, that's been one of the biggest problems in pediatric palliative care, our small, under-resourced teams working across the country doing redundant work in silos. And so the entire goal of this project is to bring people together. So we hired a project team to support our day-to-day work. We developed a project executive committee that's composed of a member of each of the specialty pediatric palliative care teams and hospices across the country. And where there's a province or territory that doesn't have a specialty team, it was actually quite interesting that an individual emerged in each of those spaces who really is who people go to talk about pediatric palliative care in those provinces and territories. So we built that committee as well as a group of really incredible partners with lived experience. So people who have lived pediatric palliative care across the country that are guiding the project. And lastly, we started to go further and look beyond at healthcare providers across the continuum of care and across the country, as well as partners who work in this space. And so oftentimes that would look like an adult hospice palliative care provider or organization that also wants to talk about children, but it's only a small part of what they do, or a children's healthcare organization where pediatric palliative care is only a small part of it. And then we've also connected with partners from different equity deserving groups so that we can amplify those voices as well. And it's been spectacular to have them lend their perspectives and lived experiences. And it's what's brought us to where we are here today. If we go to the next slide, I think one of the things for those of us that have worked in this space for some time was this truly is the first opportunity to look at pediatric palliative care across the country as a whole and to come together for the first time with resources and intention to really think about what pediatric palliative care in Canada can look like in a cohesive vision for this group of children and families and communities who need this care. So we put pen to paper on a future where every Canadian child with a life-limiting illness has access to high-quality pediatric palliative care, regardless of location, background, or circumstance. And we know, as I said before, that really the only way to achieve this is through collaboration. So we've brought to the table voices of families, of caregivers, of healthcare professionals, so that we can really make sure the work that we're doing is reflective of the needs and hopes and desires of these individuals who provide and use this care. The second part of this is where I want to make comment. So we were really intentional in the grant to put funding aside to engage with various equity deserving groups. And the reason being that in pediatric palliative care, children are often considered an equity deserving group when you have any conversations around palliative care, because they're such a small part of the population. And so as a result, a lot of the work that's done doesn't dive any deeper than painting all children and their families across the country with one brush. And so we really wanted to take this opportunity to dive deeper and to better understand what the specific needs are of equity deserving groups within this community. And one of the first conversations that I had with Holly Prince, who wasn't able to be here today, was to acknowledge that this was a closed grant application and there was no space for co-design and for sharing. And we recognized immediately, once we started working, that the idea of being able to say that in 2 years, we're going to understand and put forth a solution to what pediatric palliative care looks like for all of these equity deserving groups. And in particular, today, we're discussing Indigenous children and families, is not on the table. What is on the table is the beginning of a conversation, the search for partnerships, so that there is that opportunity to come back with co-design. And so we acknowledge that error, that upfront kind of challenge that we put by listing these groups but not having partners. And so that's why we're here today, to start this conversation with you. It hasn't gone any further than this, and we're just grateful to kind of be able, as I said, to start this conversation. So I'll tell you a little bit more about how we're planning to do this. We recognize there's so many things that need to be done to achieve this vision, but the purpose of this two-year project is to build an online resource hub. And so at present, there's a lot of sharing that goes on between providers when there is a child who's being cared for back home in community. And so we want to take all of the beautiful resources that have been developed across the country by specialty teams and by providers across the continuum and put them all together in a resource hub. Some of these will only be of benefit to these specialty pediatric palliative care teams, but by placing these things together, it'll allow them not to spend their time doing administrative tasks, but to share the work that they each do with each other so that they can spend their time providing frontline clinical care and providing mentorship and support to individuals that are working in communities with these children. There'll also be a part of the hub that's dedicated towards more of the non-specialist providers, and those resources are going to be available in French and English, and they're really going to focus on how do we mobilize the knowledge that we have and how do we make sure that we can help build capacity to have people feel more comfortable delivering this care closer to home and providing this collaborative care model that Dave has outlined. Second piece is we know PDF documents can only take us so far. And so developing a peer-to-peer network that would help people understand who to call when they have a clinical question, who to call if they're interested in designing a new service or delivering services in their community. And that will enable some sharing and learning from one another and building communities of practice that will support that as well. And the last piece is we don't currently have a vision, a shared vision of care across the country. We don't have a standard for pediatric palliative care across the country. And so this is work that we want to be a part of and that we want to help organize so that when we say what is high quality pediatric palliative care, we're able to better understand what that looks like for Canadian children and families. Now I'll pass it back to you, Dave, on the next slide.
So just briefly, over 2 years, Jane and her family weather many storms, including illnesses, admissions, new symptoms. She has severe spasticity and requires her G tube to be advanced to a GJ tube, a slightly more complicated technology. After a particularly long and difficult admission, Jane's family, her family health team, her pediatrician, and the palliative care team meet together and agree that Jane's body is showing signs that it's reached its limits. The plans to discharge Jane and in case of further deterioration, support her at home with comfort measures. Home care continues its support with familiar faces in the home. The family health team increases its frequency of home visits, both medical home visits and psychosocial home visits. The pediatric palliative care team provides recommendations for symptom management plan and supports the development of written advanced care plans and a do not resuscitate form. 3 months later, Jane spikes a fever and begins to develop respiratory distress. The family calls the family health team, who in turn speak to the pediatric palliative care program. They initiate the comfort plan with acetaminophen and routine low-dose morphine. Jane becomes comfortable over the next 48 hours. Her breathing becomes shallow, then irregular, then stops. Her family physician pronounces her as deceased. Shauna and Jim continue to receive grief support from the family health team social worker and are invited to peer group programs through the palliative care program at the Children's Hospital virtually. With the help of the pediatric palliative care child life specialist, Jesse and Jacob prepare a second presentation for their school, this time called Our Spirit Sister. At the 1 year mark, Jane's family receives a letter from their health region and a link to the Quality of Children's End-of-Life Care Instrument. This is a validated tool that they can use to provide meaningful feedback to the system on what went well and what could have been improved. So I'm going to pass to Kira for this slide.
So we wanted to just take a moment and acknowledge what we've learned so far in the project over the last year and what we still need to better understand, and recognizing we're coming close to the time that we were allotted for today, and we really do want to leave some space for feedback. So I will be brief, and it's unfortunate that you can be brief on these slides because there is not a lot that's known about delivering pediatric palliative care to Indigenous communities. There's been a lot of work done both in Canada and across the country to start to develop an understanding of what hospice palliative care looks like for adults in Indigenous communities. But there's so much variation, as you all know, distinct identities, whether you're First Nations, Inuit, Métis, where you come from, urban, rural, remote, what the underlying diagnosis is, past experience with the healthcare system, just to name a few. So even within our understanding of adult palliative care in Indigenous communities, already we know there's so much that's left to learn and so much variation. For pediatrics, we really do have not been able to find any research that's been done. We've had anecdotal conversations and experiences, but a lot of this has actually not come directly from Indigenous children and families and communities themselves. It's from providers that we've had the chance to speak from. If we want to make sure that culturally safe care is available to all seriously ill Indigenous children and families, we must understand who needs this care, where are they, what does good care look like for children and families, how are some of these needs already being met, and celebrate those innovations, and where are they not being met? What beliefs are held in communities about pediatric palliative care, and so much more. And we do know, Joanna, as you spoke earlier about Jordan's principle, there are some natural spaces that we can look at to learn more. So Jordan's principle and the Inuit Child First Initiative are some places where we may be able to learn about people that are already using these services and how those intersect with pediatric palliative care. So as I said, a lot left to learn, and a lot that we're hoping to learn over the next little while to be able to even start to forge a path forward. So for next steps, we really hope that this session starts to foster connections so that we can find partners who want to collaborate on improving this care area. We really are seeking partners that can help us deepen our understanding of the unique challenges in delivering this care. And our ask of you is, if you want more information or you're interested in getting involved, that after the webinar, you reach out to me. There's my email, and this will be sent out. And we're really hoping, as we said, this is the beginning of a conversation. We're so grateful to Holly and CERAH and Joanna and Elder Dorothy for letting us be here today. The next slide, we are doing a survey just to try to offer a space for people who don't have the time for these one-to-one conversations to share their voice. You can take that as a healthcare provider, a person who has lived experience, or both if there's an intersection. So those will be shared following the webinar. And then the last ask is we are on some of the more traditional social media platforms. So if you can follow us to help amplify the work that we're trying to do and lend your voice, you can register on the website and already give feedback if you have ideas around tools or resources that could be developed. We're looking for partners to go to co-develop those with. And this is just another way to reach out to our group. And that closes our part of the webinar. And now we'd love to know questions you have for us, and I'll pass it back to you, Joanna.
Kira and Dave, well done. I thought what you shared with us was well balanced with a story of what pediatric palliative care could look like for a child and their family, and also sharing about the Alliance and this initiative. So we had some really great comments happening in the chat, and I wanted to share some of those with you. One was for the circular model, and Kira, you had already acknowledged that that you could add community in that same circle as family. And is there a name for the child-centered vision model? Or is this something that
vision model is, yeah, this is just what I've created to represent the work that we do.
Okay, well, that was a really great visual. And I would say with Indigenous communities, we do love circular images to help us understand and see the interconnections of care. There was questions about navigation. And are there pediatric palliative care navigators roles in hospitals?
So, again, one of our goals is to stimulate these questions, right? And as we, particularly for people that choose to sign up for on the website to be part of the Alliance, like it really is meaning to be an alliance in the true sense of the word, that like, come join us, right? This isn't Kira and I. This is all of us together. So come join us so that as this grows and we look at region-specific healthcare issues, we can ask region-specific answers, because I can't give you that answer for every children's hospital in the country. But if wherever you work, you should be asking that question about your children's hospital and what resources are available and how can we partner if they're not available and how do we move this agenda forward because there are more questions than answers at this point.
Mhm.
Okay, so I know from working in the Toronto region myself, in 2022, there was an Indigenous patient navigator at Sick Kids Hospital. Now, I'm not sure if that person is still in that role, but it's something that I do want to look into after listening to your presentation. The next question I have, or a comment, you talked about in your last slides, what do we hope to better understand about delivering pediatric palliative care to Indigenous communities, but also the lack of research. I would say that explore First Nations health, First Nations Care and Society, because I think they started the research through learning about the experience with Jordan River Anderson. I see we have some more questions here. I also had a comment. You talked about resources in the English and French language. I hope there will be some advocacy to develop resources in other languages, especially Indigenous languages.
Mhm.
And we have a comment here. There are pediatric Indigenous navigators at Health Sciences North in Sudbury. Thank you for sharing that. Any comments, Kira and Dave, to what I've shared so far?
No, it's been really helpful, and I see quite a few other comments in the chat too that are really fantastic kind of leads of where we can go next with this. And I think that was the hope today, was to hear from people who have more lived experience where we can take this next. So lots of wonderful comments in the chat of where we could move from here.
So I do want to add some other comments. And you shared a case study. You did announce at the start that this case study was not specific to an Indigenous child's experience. And there were some resources, supports, for this family. But what I would say in my experience in working in palliative care with adults, I would say the pathway could look different in terms of access to supports, as well as how we would approach conversations that have a culturally safer component to some of the conversations. And we had a comment about Indigenous children really need a distinctions-based framework. So I hope that in your engagement with this strategy, that there could be some recommendations when it comes to providing, palliative care for Indigenous children.
Yes, I know the current framework, there's work underway to develop a distinctions-based framework for Indigenous adults with Health Canada. And Robin, who's on the call today, was there with us when we were chatting with Health Canada about just that there doesn't seem to currently be a place or a space where this is being looked at a Canadian level. So I think that that's really, really true, what Robin is saying and what you said, Joanna.
And Kira, I really appreciated how you had, shared that at the start of this project and, putting this funding grant together, that the lack of Indigenous knowledge and engagement, and that this is something you're learning to do now, and you don't have a lot of time as well with 2 years. So there was a list of partners, and in the comments, it was recommended to partner with those Jordan Principal offices.
Mhm.
And so I hope you will take note of that. But partnership will be really key if you're going to be developing any frameworks that are going to be impacting, Indigenous children and their families.
Absolutely.
I have another comment.
Please.
So I provide education, palliative care education, in 3 Indigenous designed, led, implemented palliative care education programs for First Nation communities. And I do advanced care planning education, and it's one of my passions and topics. And Jill Marcella is also on the line here, and we do this work together. And I'm so curious, and I hope that there'll be opportunity for us to learn about what advanced care planning looks like with children and their families, because my experience is with adults. So because I'm so passionate about advanced care planning, that I want to learn about children and families.
I have a very brief response to that connects to some of what we've been talking about, which is recognizing that geography is a significant problem in pediatrics. Children getting sick enough to be life-threatened is not the norm, right? It's not typical. It's relatively rare, and so they are virtually always getting care from a specialist children's hospital somewhere across the country that serve these vast geographies. And so that is necessary. Care there is necessary because of the sort of rarity and specialization of their care. And yet community expertise, cultural expertise is so important that we can't do this without partnership, right? If the hospitals, even when there's, let's say, an Indigenous navigator present in the hospital, that doesn't mean that there isn't value with engaging specific elders or supports in their specific community, in their home, right? And forming those connections and supports early. And I would say, the same goes for advanced care planning. Advanced care planning in pediatrics, it is prognostication in pediatrics is notoriously difficult. So there's often a lot more uncertainty, a lot more of if than this, but there is when it is happening in the hospital, there is a need for a spiritual lens and community partnerships and cultural guidance. When it's happening in the community, there is a need for sort of pediatric hospital expertise. And so I think we really need to leverage partnerships. This is all about partnerships. And one of the reasons why, it's less beneficial, which to answer the question of is there a navigator? We could just put a list of all the hospitals that have a navigator. That's actually not as helpful as someone then asking the question, because that's a connection, right? And that connection can lead to a meeting, and that meeting can lead to a partnership. And we really want communities, both on the hospital side and in rural communities and Indigenous communities, but to be standing up, saying, not waiting for a crisis and then seeing if they can deal with it, but standing up and saying, how do we get ahead of this? How do we form these relationships and partnerships so that we can handle this for all children?
Great. So 2 more questions. Is there palliative care training, pediatric palliative care training for healthcare providers?
I'll give that one to you, Kira.
Yes, there is some pediatric palliative care training. So currently, through organizations like Palliative, there is training called LEAP Pediatrics. I've taken the course myself, and it's a dense course. Vicky, who's on the line here with us, Vicky Wilton, is one of the LEAP pediatric facilitators, and we've chatted about it. It's a dense course, very informative though. So some of the conversations we're having with Palliative are around how we can embed pediatric palliative care knowledge into all palliative care education, because ideally all palliative care providers and all providers taking these learnings would learn about children while they're learning about adult palliative care. But there are specific pediatric palliative care LEAP courses that are available. And then a lot of the teams themselves will kind of organize trainings for their regions and their communities. And then I know I was on Vicky's ECHO session the other day about delivering pediatric palliative care in the North. That was delivered through Palliative. So it's one of the things the Alliance is hoping to take on, is making sure the right type of education is available at the right time parsed in the right way for people. And at this time, there would be no available pediatric palliative care education specific to Indigenous children and families, but it would be quite remarkable to create something like that to share as well.
Okay. Wonderful. I see we've reached our time here. So I want to just share that in the chat. There is somebody from that works in First Nation community that is interested in partnering, collaborating with you. So please take note of that. And before we close today, I just want to thank you, Kira and Dave, for sharing your work in pediatric palliative care with us. I want to let people know that there will be another webinar on December 11th called A Culturally Humble Approach to Palliative Care with Rani Shami. And Jess will add the link to register in the chat. And before I invite Elder Dorothy to say some closing words, please take note of the evaluation that will pop up after the session is over. So I want to thank you all again for attending this webinar and providing your feedback. Dorothy?
Thank you, Joanna. I'd also like to say miigwech to Kira and to Dave. And I'd like to honor the work that's being done towards Indigenous child and families in palliative care. Really honoring this work that's being done and welcoming the request for partnerships. I'm sure that from the request that we have today, you'll get quite a few partners. It's a big, big task, but we're up to it. And as much as we can, we're here to help you. Miigwech.
Miigwech, Dorothy. And so I hope that Kira, Dave, this session has been recorded. I know that there are people who have been emailing and asking about the session being recorded, so it is. Please stay tuned. Keep a lookout for an email from Jessica to share the recording with you. And so with that, we thank you all. Have a wonderful day.